Greetings and welcome to this video on hepatitis C virus. In this module, we'll discuss about the virology, epidemiology, and the diagnosis of hepatitis C. So, this is completely for educational purposes and for practicing physicians and for medical students who are learning medicine. So, this is Medicine Beyond Horizons. Let's get started. So, why you must know about hepatitis C is because hepatitis C is now curable. So, many patients on randomly checking for a viral serology before surgery get detected positive with hepatitis C, and then you don't know what to do with an hepatitis C positive anti-HPC total positive. What to do with that? So from this lecture or this module, we discuss about hepatitis C virus in overview, and the next module we'll discuss about the treatment. So introduction, it is the one of the most leading indications for liver transplant worldwide. The prevalence of around 0.7 percentage of the global population and estimates about 56.8 million viremic patients throughout the world. So this is a major by infection in the world causing liver dysfunction and the liver transplantation. So that's why you need to know about this in detail. So nowadays, from 2014 onwards, with introduction of direct-acting antiviral drugs, there is a rapid downfall in the prevalence of hepatitis C, and pan-genotypic direct-acting antiviral drugs, which was introduced in the last 5 years, significantly improved the management. So now hepatitis C is actually curable. Yeah. So global epidemiology data from 2015 it was 63.6 million. Now it's come down to 56.8 million with decreased new infections rate, increased cure rates, and decreased death due to hepatitis C. All these are due to the new introduction of the direct-acting antiviral drugs that we'll discuss in the next module. So hepatitis C virology it contains of it is an RNA positive ssRNA positive virus. E1 E2 glycoproteins are present as the outer coat, so it is from the family of Flaviviridae and Hepa C virus genome. And positive single-stranded RNA is present with RNA packed by core protein. So there is a lipid bilayer in the hepatitis C virus coded by the E1 and E2 glycoproteins. So HCV life cycle is very simple. As an virus, it enters into the organisms through OCLN and CLDN1 protein, and it just gets uncoated of its genetic material, which gets into translation process with polyprotein synthesis and replication and formation of replication complexes, which again assembles into the lipid droplets and finally gets exited into the cells to infect other cells. So the main thing in this hepatitis C virus translation process is that it attaches to the rough endoplasmic reticulum of the cell. This polyprotein is cleaved into structural and non-structural proteins, which we target for treatment. So non-structural proteins are NS2, NS3, NS4A, NS4B, NS5A, and 5B. These are the proteins forming the replication complex. These are the major targets for direct-acting antiviral drugs. So viral assembly occurs in the endoplasmic reticulum. This you must remember. Variants released using lipid droplets. That is also you must remember. The clinical difference between HCV and HBV is that HCV does not integrate into the host genome. That is why it is comparatively easier to clear of HCV infection and achieve a possible cure, which is unlikely in hepatitis B virus. So there are 8 recognized genotypes and almost 86 subtypes in hepatitis C, of which genome 1 and 3 are very important to remember. Genotype 3 is dominant in South Asia, especially in India, associated with steatosis and faster progression. The most common worldwide is the genotype 1, and 1B is associated with higher HCC risk. So others are genotype 4 in Africa and Middle East, genotype 5 and 6 in Southeast Asia and South Africa, 7 in the Republic of Congo. So mainly you must remember the genotype 1 and 3. 1 is most common worldwide, plus 3 is most common and dominant in South Asia and India. So transmission, it is parental route is the most common route of transmission with blood transfusion, unsafe injections, needle stick injuries, hemodialysis, IV drug abuses, the global number one cause in the Western population, especially. Also, tattooing in unsafe places. All these are causes for transmission of hepatitis C virus. So, sexual transmission is also present, which is uncommon, higher risk in male sex workers and other sex workers. So vertical transmission about 25% risk if mothers is HCV positive. India unsafe therapeutic injections are the major driver of HCV. So with safe hygienic injection strategy in India, we can almost cut down the rate of HCV transmission. So acute infection usually is asymptomatic and leads to less than 1% of acute liver failure causes. So it has spontaneous clearance of around 10 to 50 percentage. Factors of female IL-28B and HLA-DQB1, all these are favorable outcomes where there may lead to spontaneous clearance of the virus. So in chronic hepatitis, there are almost 50 to 90% progress to chronic hepatitis in a mean time of 25 years. The medium time to cirrhosis is 25 years from the occurrence of chronic hepatitis. So from cirrhosis, it can go into decompensation or hepatocellular carcinoma. So this is why you need to treat hepatitis C virus to prevent decompensation HCV, HCC, which is a highly preventable complication of hepatitis C virus. So whenever you do a test properly for a surgery, before a surgery, or while admitting into the wards to check for virus serology, you suddenly detect HCV antibody is positive. So what to do? So when HCV antibody is positive, when it's not positive, there's no infection. That is ruled out at first itself. So when it is positive or reactive, then test for HCV RNA. There are two types, which can be quantitative or qualitative. So there's no point in doing a quantitative analysis, because whenever HCV is detected in qualitative analysis, you must need to treat the virus. So it is almost curable. So whenever the HCV RNA is detected, that is with the qualitative method, you must treat. So when it is detected, current infection is to treat. Not detected, no current infection, so no need to treat. So HCV core antigen, this is also another test that we can do. It can detect recent infection, less sensitive than HCV RNA. If RNA or core antigen is negative, repeat after 12 weeks. So in immunocompromised, test HCV RNA even if antibody is negative. This is important. So in case of initiation of dialysis in immunocompromised CKD patients, they always do HCV RNA even before putting in HIV catheter or doing in dialysis to prevent infections, as they are all for HCV as well as immunocompromised. So in case of reinfection, suspect if RNA is positive if more than 12 to 24 weeks post SVR, sustained viral remission. So HCV serology timeline. So HCV RNA is detected in 2 weeks. It can go down if when RNA disappears, and ALT can rise for around 8 to 12 weeks in the acute infection. Then anti-HCV titer starts to rise at around 12 weeks, and it persists for a long time, for years together. So RNA disappears after sustained viral remission, that is cure. Antibodies persist for life. So acute hepatitis is asymptomatic in more than two-thirds of cases, rarely detected unless screening is done. So chronic hepatitis, fatigue is the most common complaint. The patient comes with generalized fatigue, tiredness, with a mild upper abdominal tenderness, cognitive impairment, brain fog, abdominal pain, and pruritus. So in all these cases, you can go into decompensation with ascites, septic encephalopathy, peripheral bleeding, and jaundice. So there is a one entity called fibrosing cholestatic hepatitis in its hepatitis C. It is a critical emergency seen in immunocompromised patients, especially post-transplant. There will be severe jaundice, coagulopathy, and encephalopathy, death within 4 to 6 weeks without intervention. This is caused due to hepatitis C virus in post-transplant or an immunocompromised patients, called as fibrosing cholestatic hepatitis. So hepatitis C virus have a lot of extrahepatic manifestations that you can detect clinically when you suspect hepatitis virus in a patient coming to you with an LFT report showing mild AST, ALT increase, as you suspect to have him having a chronic hepatitis, and test for hepatitis serologies. Then now you can go in for look for extrahepatic manifestations, and extrahepatic manifestations of HCV are many. So generally, it can present with fatigue that will increased insulin resistance, leading to diabetes, stroke, MI, depression, cognitive impairment, and rheumatoid arthritis. All these are extrahepatic manifestations which are systemic. Organ specific, there are few manifestations such as MPGN and Porphyria Cutanea Tarda, lichen planus, B cell lymphoma, and hypo and hypothyroidism. So whenever you detect an HCV RNA positivity, always look in for like serum creatinine, then suspect B cell lymphoma. If there are presence of B symptoms, hypo and hyperthyroidism, you can do a screening TSH analysis. Also look for lichen planus in the skin. So other important extrahepatic manifestations are cryoglobulinemia. It is almost seen in 36 to 54% of HCV positive patients and not the vice versa. So always look for palpable purpura, glomerulonephritis, and arthralgia in a patient with cryoglobulinemia with a Melzer triad. You can go and refer back to Melzer's triad, which is mixed and non-mixed cryoglobulinemia, of which mixed cryoglobulinemia is seen in hepatitis C infection. So treatment of hepatitis C itself resolves the cryoglobulinemia in most cases. If not, in case of HCV negative cryoglobulinemia, you can go for rituximab therapy. So this is called Melzer triad with palpable purpura, glomerulonephritis, and arthralgia. So metabolic complications like insulin resistance, if it is present in the patient with hepatitis C virus positive patients, then it can lead to fibrosis and hepatocellular carcinoma. There is higher cardiovascular risk of more than 1.5 times increased when the patient is infected with hepatitis C. There will be palpable purpura in up to 90% of the patients. So whenever you see a palpable purpura, also keep in mind to look for hepatitis C virus in that patient. The lichen planus, necrolytic acral erythemas can also be the extrahepatic manifestations of hepatitis C virus. So in this module, you would understand about the virology, epidemiology, clinical features, and the common extrahepatic manifestations, and the common diagnostic approach to an hepatitis C virus, and the anti-HCV positive status, and how to evaluate it further. So in the next module, we'll discuss detailedly about the treatment uh, process of the hepatitis C virus and when to say hepatitis C virus is cured. So hope you loved watching this video. If you're first time to this channel, do subscribe. This is Medicine Beyond Harrison's. Thanks for watching.